Welcome back to Radiology Rewired. I'm your host, Dr. Vivek Singh. Today we're going to be talking about the future of artificial intelligence and what's coming next in this tech. Particularly, we're going to be focusing on the new preventative techniques that are being developed by these new AI algorithms and how it's going to affect clinical care and potentially stamping out disease before it has even happened. Moving on to our keynote articles for this episode. This episode comes from UC San Diego Health, titled AI Surveillance Tool Successfully Helps Predict Sepsis and Saves Lives. So sepsis is basically going to be a constellation of symptoms that predicts the mortality. You can have high fevers, elevated heart rate, and elevated respiratory rate, and basically tells the clinician, hey, something is really wrong with this patient. And when you're exhibiting those types of symptoms, the chances of your mortality go up significantly. This is often related to infection or other factors going on with the patient. The problem is monitoring for this stuff. When do you get the combination of these fever, heart rate, all this type of stuff that tells you, hey, this patient is trending down and you really need to care for them more so than the other people who are filling your ICU. What they found was when they applied this artificial intelligence model called the composer model, they looked at 150 clinical variables for each patient in that setting. And they were able to predict sepsis from occurring before it even occurred just based on these various parameters. This resulted in a 17% reduction in mortality. This is huge. If you're able to use these factors that we're already measuring in the ICU to potentially predict which patients are going to do worse and ensure that they are treated early, you are really moving the needle, and it's really exciting technology for the future. The second article I wanted to talk about comes regarding Google Cloud and their MedPalm multimodal foundational model. What this is a basically comprehensive model that factors in all the clinical parameters for the patient: age, weight, height, past medical disease, lab values, imaging, and greatly just kind of compacts all that information and is able to spew out a report about the patient, what the suspected diagnosis might be based on their current presentation, and what treatment recommendations it has. What they found is that this model performs really well as a whole patient kind of comprehensive guide looking at all these different factors. It's really valuable. What they did notice, though, is that the recommendations can often be hallucinated and skewed toward the bias during these evaluations. And they found that the way to really go about fixing this is to constantly monitor the outputs and to provide more information, give it information if it's making an error or if it's biasing one way or the other. And I think this article really highlights what is going to need to be done for all AI systems in the future. It's going to need someone to monitor the outputs, it's going to need some new inputs to improve, and it's going to gradually improve to the point where we can actually rely on these to make good recommendations without hallucinating. Hey everybody, welcome back to Radiology Rewired. We're at the interview portion. I got a really special guest for you. We've got the Chief Business Officer for RapidAI, Dr. David Stoffel. He's an MD, MBA, did his medical school at Stanford. Is that correct?
No, undergrad at Stanford, medical school and business school at University of Chicago.
Okay, awesome. So you have a really unique perspective in that you've gone from the medical side through, venture capitalism to kind of running a startup now. So kind of take us through that because it's a really unique path in medicine.
Yeah, well, first off, thank you for having me today. We're big fans of the podcast, so we appreciate the opportunity to be here. Um, yeah, I mean, I think about my career, I've kind of Forrest Gump my way through it. I went to medical school and with the idea that I was actually going to get a PhD in economics at the same time. And I was going to be some ivory tower, economics medical person. After about 6 months, I figured the economic side wasn't going to work. And so I was there in medical school, figuring I'd just go into surgery, and had the opportunity to go to business school. And it just kind of blew my mind. It opened my eyes, not only about business, but what the healthcare aspects of business and what an MD could do in business. And that for me really changed the trajectory of everything. I did a investment banking internship and I was trying to pay off some debts for a wedding. So I took that. But did that, and the rest is kind of history. I just stuck with it and went into venture capital and industry, as you said.
Yeah, and you have a background in this Da Vinci surgical device, which is, massive these days. So, can you talk a little bit about the hardware development and that process versus what you're doing now in artificial intelligence more on the software side?
Yeah, and I think if I take a step back, what I've always been interested in are technologies that change the standard of care and something that's going to be pushing the horizon forward. And so that's really what kind of got me interested in business in the first place is, if you look in medicine, for me, I love what doctors do. I'm married to a doctor, dermatologist. And so my entire family is in medicine. The difference for me, though, was being able to push the horizon for hundreds of thousands or millions of patients through technology adoption and changing that standard of care. And for me, I've looked at my opportunities in my career of joining companies that do that just thing. And for Da Vinci surgery, I joined it for surgical robotics. You joined it at a time when it was just starting to get adopted in urology, and people were saying, "Hey, it's a fad. It's something that's kind of a marketing gimmick." But I saw it something differently, and the first off, the people there were amazing. Technology was amazing, but what you really saw was a technology that was enabling physicians to do something they had never done before, which is open surgery really dominated the surgical theater. So if they could talk about minimally invasive and laparoscopic surgery, but the majority of what they did was still open. And what the robot did was enabled them to take an open surgery and do it from a minimally invasive perspective. And that to me was just amazing. And that to me, the possibilities were almost limitless when you started applying that broadly across surgery. So that's just an opportunity of whether it was hardware or it was software, it was changing that standard of care. I kinda look at it now. I'm at, RapidAI. I kind of view it similarly with, Rapid has changed enabled people to get treated for stroke who were never able to get treated before by the information that they're delivering to physicians. They're doing that now for hemorrhagic stroke, for aneurysm, for PE, for aortic. They're spreading that across the disease, across the body. So I kind of view whether it's software or whether it's hardware, I could see the development of successful technologies are really things that are pushing that horizon forward and changing that standard of care. And how they do that, might be a little bit different. Obviously, with software and it's diagnostic, you're giving information to people to make decision making. For hardware, it might be enabling them to perform a procedure, maybe in a minimally invasive way that they weren't able to do before. But at the same time, both of them lead to the same spot of changing that horizon and pushing that horizon forward.
So you used to work on the Da Vinci robot, which is obviously hardware, but a big innovation in surgical care. And now you've transitioned over to the software side. Can you talk a little bit about the difference between the two and what it really meant for you to work on these projects?
Yeah, I think I'll state the obvious first is that software, the cycles are so much faster. With hardware, you have to do iterations, there's supply chain, and so the pace of change is a little bit different. Software, it's just lightning fast. I think there are more similarities though than differences. Because when you look at technologies that the market that really matter in the market that get adopted, whether it's a surgical robot or whether it's AI, clinical AI, the things that are matter are the things that move the horizons forward. It changes those standards of care. A surgical robot moves a lot of open procedures over to minimally invasive. Software, when it's done right, is going to help you make better clinical decisions and it's going to help you move faster. And so I think that the market speaks in a way that says, "Hey, we want technologies that are going to push the horizon forward." And so I think there are a lot more similarities in how they're adopted than differences.
Okay. And I'm like very interested in your take as someone who's been in the venture capitalist industry and has evaluated startups as they come in and are being developed, or even sometimes have development and need funding. So, on the private industry side, how do you guys look at these things and decide what's actually viable, what you're really encouraged by, and how do you make those decisions?
Yeah, and to me, there's three simple questions that are easy to ask but hard to do. And it really comes down to when you're evaluating a technology. And this goes for a company you want to join, a company you're trying to invest in, or anything. For me, there are three things. The first one is clinical value. Does it deliver clinical value? And we kind of spoke about that earlier, but what is clinical value? It's you getting information that's actually changing your decision making. There's a lot of AI out there and stuff that just doesn't matter. It gives you information, but it doesn't change what it is that you do. So therefore, it didn't add any value. That then is there's actually a study for AJNR that looked at 100 AI algorithms that were cleared by the FDA, and 88% of them, they said, didn't change any clinical decision making. Only 12% actually mattered. So you can see why there's so much noise out there. But I think that first criteria really boils down to, did it change clinical decision making? And that to me is clinical value. The second part of it, though, is the hardest one, and it's the trickiest one, and that's operational value. And what that means is you can't just have this information, but does this information slow you down, or can it take friction out of the system? In other words, with this information, can you go faster or do something faster than you otherwise would have? So many technologies, even if it is better, if it slows the physician down, if it slows the radiologist down and says, yeah, it's great, but now I can only do half the reads that I used to do before, it's just not going to get adopted. So, really successful technologies take friction out of the system and help people go faster. The third criteria is really hospital value. Can you look at this and figure out a way that the hospital can actually see a reasonable ROI on it? Whether it's incremental procedures, whether it's a lower length of stay, better transfer rates, and so on and so forth. It should have an impact that matters to that hospital, because we live in a world where hospitals have to purchase things and it has to be cost effective in order for them to adopt it. If you get all three of those criteria, you've got yourself a great technology.
Yeah, and I think about clinical, operational, and hospital value, like, we've talked about so many different AI platforms, and the one we always keep coming back to, and not just because, you're part of the company and all that kind of stuff, but in the end, stroke care is, like, I think one of the premier examples of when AI is actually helping. Like, they're talking about operational value, getting people to treatment earlier, having those neurointerventional teams ready already, getting that clinical information about the mismatch stuff, and actually dictating whether a patient is going to get a thrombectomy or not. And then, of course, with the hospital value, we talked a lot with the other neurointerventionists about how they were so used to getting patients transferred that were maybe just drunk and not having a stroke, and the sinking cost that occurs in a hospital system on both ends, because the person who transferred that patient over is losing money just from not being able to keep that patient and take care of that patient who otherwise doesn't need a thrombectomy. And so I think those three components are really, really, like, it's great summary of like what we're actually looking at.
Yeah, and I think that's a great summary. And you could take those lessons and not only apply them to stroke, like ischemic stroke, but apply that to hemorrhagic as well. You could apply that to aneurysm. You could apply that to aortic, pulmonary embolism. All these different disease states that we're now covering have that similar model of, you're finding the disease, you're helping the physicians make faster decisions, you're disseminating that disease, the information, allowing them to make fast decisions, and the hospital benefits by getting better patients and better care for their patients.
So do you think that's maybe why some of these early AIs have kind of skewed toward the more critical findings, because they do end up providing the most value if they do work well?
Yeah, I mean, it's a great question. I mean, I think right now we're in a phase where you go to any place like at RSNA, and it looks like AI was just someone took a bucket and threw AI everywhere, right? And it's like, it's on billboards, it's on, trash cans, it's on everywhere. And so we're really in this phase where I think the market is we're kind of awash in different solutions, and the market has to figure out what it is that matters. But I think those criteria that you just articulated and we were just talking about, that will ultimately decide which of these AI algorithms we're still talking about 2, 3 years from now.
So, along those lines, when a hospital has actually bought a, AI software and they're evaluating the ROI, how often are they actually investigating the returns on it? Is it every 3 months, 6 months? And like, when do they pull the plug and decide, hey, this technology is not for us. It's not paying dividends for us?
Yeah, I can tell you that as a company, selling into a hospital, you wanna highlight that value that you're demonstrating for the hospital. So if that hospital's bought a technology and they don't know its ROI, they don't know the impact that it's been having 6, 12 months after it's been purchased, shame on the hospital shame on the company for not being able to highlight that value. I think it's really important that hospitals are busy. There's a lot of data being tracked, and so that's one of the things we have at Rapid. We have a data, insights platform, which tracks all the results and all the impact that Rapid has within your hospital. So you can access that and say, hey, this is how many patients we're seeing. This is how many patients we're treating. And it makes that impact really accessible. And so I think I'd kind of flip that question around and say, companies have an obligation to be able to highlight for the hospital and make it easy for them to see the impact that they're having. And if they can't do that or they can't have that conversation, I think it becomes really hard for that hospital to see how that technology would have a future there.
Yeah, no, that's a great point, and I mean, you're bringing up how these are kind of the 3 criteria that you decide that, were those similar criteria when you were deciding whether some to invest in something, if as in terms of a startup, you're looking at those 3 key factors?
Yeah, I mean, I think that when you're looking at for an investment too, you always and it matters in terms of the clinical value. Does the clinical question actually matter? You can answer a lot of different clinical questions and say, yeah, that kind of matters, but does it actually matter in terms of pushing? I get back to that pushing that horizon forward. And so I think as a venture capitalist, whether you're an entrepreneur, whether you're a venture capitalist, you're always looking for companies that are trying to answer the big questions because, look, we want to spend our time on the things that matter and you want to invest in the things that matter. And so I think those are kind of one and the same, but I think answering those big questions is an essential thing part.
How do you see things moving out of the radiology AI space? I know you're kind of mainly working on that front, but I'm sure you get exposed to some of the new things on the horizon in terms of the broader clinical picture that's going to affect not only just radiologists, but clinicians, healthcare systems, predictive technologies. Can you talk about what you've been seeing in the AI space overall?
I think the true promise of AI is that it can eliminate a lot of the standard deviation in healthcare delivery, but it also can raise the ceiling of what's possible. And what do I mean by that? Um, right now in stroke care, you take for example, or hemorrhagic care, you could show up at one hospital and not get scanned. You can get one scan and not to have a transfer decision for 4 or 5 hours. Why is that? Is because they don't have access to the radiologist. They don't have access to the neuroradiologist. It takes them a long time to make these decisions. So, one of the things that Rapid has is the ability to diagnose a stroke or an LVO off of a non-con CT. That's a perfect for these types of rural hospitals who might not have these fast imaging protocols. So you can signal almost right away when that patient needs to be transferred. And what we've seen is that this can cut 40 to 60 minutes off of a transfer time for a patient. And when you think about it in terms of a stroke, where 1 minute is millions of neurons, and the difference between walking out of a hospital and being wheeled out of a hospital, that's a huge impact on patient care. So all of a sudden, now you're getting to where you're going to a rural hospital and you're getting diagnosed as fast as you would have if you walked into the hub. And that to me is the real promise of what AI can deliver is delivering on that equity of care where everybody can get a really great outcome no matter where they show up in the healthcare system.
Yeah, and I've seen that kind of happen in my setting where we have, big academic hospitals, but we also have community hospitals. And I think there's certainly been a big push to incorporate perfusion imaging in these smaller hospitals that didn't have it before because of these new technologies that are emerging. Because before, even when you did adopt perfusion and invested in it, you still had to have the people to interpret it. You still have like all these factors come into play in terms of is this actually providing value? But now that you have these AI algorithms that are running in the background, I feel like hospitals have a much higher incentive to go ahead and invest in that perfusion technology because it is going to impact care for their patients and they will be able to get that more expert opinion. Even if you have a general radiologist using the help with AI, it's always going to be better than someone without it.
Yeah, and it's like almost having a neuroradiologist in every single hospital watching all the strokes. And that's or all the scans. And I think that's what AI can deliver is almost that help deliver is that expertise to anywhere in your hospital network. And that's a pretty exciting thing to see.
Yeah, and some people have looked at the flip side and been like, well, all these AI technologies are very heavily adopted and skewed toward academic centers. They're getting so some people are like, it's almost increasing the disparity of care. Like these guys go, to like this big academic center and they get, 10 different AIs run on them and predictive technology, whereas someone in the rural environment is just sticking to their normal stuff. So I think we're still at this phase where, yeah, it's like equating care, but it's also just like, creating a gap. And we really got to find ways to integrate more and get it across the country and get it more into these rural sites.
Oh, I totally agree. And I think that the technology adoption is not always led by the academics. It's actually many times led by the more rural sites or the mid-market sites because they're the ones trying to solve a problem where the academics might be trying to evaluate it. And so we love working with the rural sites in terms of we've seen them adopt early technology and have that impact and they're willing to experiment more because they know there's a problem and they want to innovate in order to address it. And so I've seen it, you can see it both ways.
So tell me a little bit about you. You had touched on this, but you had mentioned that there's all this noise in artificial intelligence, all these new algorithms coming out that do specific tasks, and they might do them well, but they don't move the needle, right? They don't move the needle in terms of like you said, those operational value and the hospital value and all that kind of stuff. I've seen that in my own experience where we, maybe get like a nodule detector or a compression factor measurer, and it's there for a few months and then just kind of falls off the map because someone decided it wasn't important enough or anything like that. So for these new startups coming out, like, is the ultimate goal just like you have to, like, your main focus should be providing value? Because right now it seems like let's try to figure out how we can do something better than a radiologist. And it seems a little bit discrepant in terms of what is actually meaningful in healthcare.
Yeah, and I mean, there's the saying, "On not all AI is created equal," and that is 100% true. Because what you just described, I think we see more often than not is if it's just a simple triage platform, there is value in triage. I don't want to put that, but sometimes if it's just triage, where it says the AI algorithm says, "Hey, there's a problem on this image, you need to go find it." All of a sudden, that radiologist has to go and find that problem. And because technology is not perfect, it's not always there. And so what we do is at Rapid is recognizing that we always try to give you localization and visualization of that lesion. So you'll be able to very easily find it and say, okay, yes, I agree. No, I don't agree. But you're not wasting time trying to figure out, okay, what did that algorithm say? And that's many times what we see with these technologies that fall away. And these people say, it didn't really add any value. What they're actually saying is that, man, it slowed me down and it didn't change my decision making. It didn't give me any information that was actually actionable. And so I think with that lesson, and that's a lesson we learned in stroke, is that you have to be able to give that visualization. You have to be able to characterize things. And that's a higher level of FDA clearance, and that takes more time. But I think that's worth it in terms of the impact in the hospital and the stickiness you're going to see in the hospital. Because that's, we said earlier, I think a lot of these AI algorithms are going to go away just because of the reason that you said. Because in the end, if it slows you down and doesn't add any value, you wouldn't even use that in a kitchen appliance, let alone, in your healthcare
Not to mention you're
system.
paying,
You're paying
thousands of
money for it,
dollars
right, yeah,
every month
you're
to
paying
use
money
it.
for that, yeah,
Yeah, it's
you're paying money to go slower and not
yeah.
make any good decisions, so
Yeah,
yeah.
and I think we talked a little bit about, radiology and burnout and just how, things have progressed in the past, 20 years. Technology's advanced. A CT scan of the head used to be like 15 slices in the glory days of when, you have these old attendings talking about it. And now we're looking at like, 1,000 slices and then reconstructions, canal views, like all these permutations to be more sensitive about stuff. But at the same time, it's just more and more images that you have to comb through, and you're liable for every pixel on every single image. So a lot of radiologists, especially ones who are experiencing this AI fatigue, where it's like they're adding on tools, but it's not doing anything, it's not moving the needle for me. They get really frustrated when there's just another output to evaluate when it really doesn't bring any value. So I guess my point is like, the burnout and like ameliorating burnout is not going to happen unless we have useful AI tools like you're mentioning that are actually going to be helpful. And I think that's what the industry is kind of realizing now.
Yeah, and if it's worthwhile, I mean, it's just one more alarm, one more bell, one more whistle. I mean, you think about your own phone, how many apps do you have that have completely useless, notifications? Yeah, you're gonna delete that app. It's the same thing with radiology, and if it's just one AI that's gonna give one more alert, one more alarm, the counter to that is, "Oh my gosh, is it not alarming me when there is something there?" It's the missed, things, and that's an equally important side of that equation because you certainly don't wanna miss anything and have the AI give you a false sense of confidence. And so, again, we try to design everything to have mid-90s, sensitivity and specificity, and we keep iterating and investing in that innovation until you're in, the high until you're in the high 90s, and I'll give you an example. We started out with our ICH module 1.0, um, mid-90s type of, sensitivity and specificity, and now we're on version 3.0. That's 98% sensitive and 99% specific. Same thing with aspects, same thing with our LVO. It's continually investing in this, innovation, and that's a tremendous thing about AI, is that you do get access to this information and these images that enable you to improve your algorithms over time.
Is it more the hospital's responsibility who bought the AI to monitor the outputs and ensure that they're not making mistakes, or is it more on the company to individually monitor each hospital's outputs to make sure that their technology is not skewing one way or the other?
I think what you just described is really, really important because to me, it's a partnership and a program. If you just dump an algorithm or a system on and you don't have this 24/7 service, like live support, you don't have live people working with your folks to, okay, now we have this algorithm. How are you going to change your workflows and to take the most advantage of that? If you don't have that data platform and analytics that can show you and give you feedback of where you're optimizing, then it's just then all they are is a vendor, and they just delivered an algorithm for you. I think what we try to do, and I think you successful programs out there, or successful companies deliver programs. And that to me is a program is like you're not just delivering the technology, but you're helping them optimize it and then giving them feedback on how to, manage it over time. And so I think to answer your question, I think it's a collaboration between industry and the hospital.
Yeah, I think that's probably the ideal way to do it. In your opinion, are a lot of these new companies doing that successfully, or is it kind of just selling the product and moving on to the next site to sell the next one?
Yeah, I mean, the temptation when you're a young company is to sell it and move on to the next one. But I think if you want true stickiness and a relationship with that hospital, you have to deliver programs. And that's what we strive to do. Those are the companies that I've always affiliated myself with, try to do just that. Because I think that's true staying power in the marketplace. And actually, more importantly, delivering real value for the hospitals.
In a very competitive market in AI where multiple different vendors are working on the same problem, how do you compete and really sell yourself to a hospital system?
AI isn't just assisting anymore, it's anticipating. RapidAI is leading the next wave of innovation, transforming imaging insights into predictive and prescriptive intelligence. From uncovering critical incidentals to helping clinicians anticipate patient trajectories, RapidAI bridges the gap between research and real-world care. Built on deep clinical validation and trusted by the world's top hospitals, RapidAI is defining what comes next in healthcare.
First off, we welcome competition because I think it always makes you better. That being said, you can't be overly concerned about the competition. And at Rapid, whether it was intuitive, whether it was at Rapid, I think if you concern yourself with the questions that matter, it's like, what is that horizon? What is that standard of care that we're trying to change? What is that, outcome that we're trying to deliver? If that's kind of your North Star, you're actually going to compete very well because you're focused on the questions that you think are matter and you're going to answer them in the way that maybe your competitors might answer them differently. But if you're just worried about what your competition is doing, you won't get those big innovative leaps forward. You just kind of say, hey, if they kind of do something, we have to copy it. I'm much more interested. Rapid does this. I'm much more interested in focusing on in competing by focusing on the horizon and saying, hey, this is the standard of care we're trying to change.
Who is your source for getting, I guess, inspiration for your next technology or your next horizon? Like, where are you guys getting this information? Like, who's telling you who needs it the most?
I mean, inspiration comes from everywhere, right? I mean, it's from your colleagues, it's having great colleagues, it's having great conversations with physicians and for hospitals. But I think one of the biggest inspirations you can have is have relatives going through the system, and just to see how they experience things. And unfortunately, I've had relatives affected by stroke, and you could see the care that they many, many years ago, 10 years ago, and you see how they suffered and those to me are the biggest motivations, but also the biggest inspirations in terms of like, hey, these are there are still big questions and big problems in healthcare to go tackle. You really see it. Like I said, if you have a relative gone through it, I think they're pretty obvious. But that to me is motivation and inspiration.
And for these new startups that are coming out, I know you were talking about how you look at operational value and hospital value for a brand new technology, brand new algorithm that hasn't been tested yet. How do you guys evaluate those in their infancy when they're just something new?
Yeah, I mean, I think that we go back to the fundamentals. Is this a question worth answering, and can we give them information that matters? And if that algorithm is worthwhile and it's going to do that, man, that's something we'll go after. But I think you have to be very clear-eyed and very honest about whether this information is actually useful. And then, if it's useful, can we translate that into a way that helps people go faster? I think we're developing a workstation for radiology. Um, and
Something integrated, please. Like, yeah.
Yeah. Oh, 100%. The workless prioritization. It has an AI orchestrator that allows you to manipulate all the measurements and all the images before committing over to PACS. It'll have the ability to translate automatically all the measurements over to your notes. And that's just an example of taking that and enabling you to go faster and taking that information. So it's not just one. I guess what I'm saying is that it's not just one algorithm. You have to have that complete thought of how it's delivered and then the outcome it's delivering to the hospital. And once you've had that complete thought, then thing's ready for development and ready to go.
Do you think imaging companies or AI companies that are related to imaging are now, it seemed like when it first started, it was almost like, how can we do it better than radiologists or get them, make them like not needed for this task necessarily? Do you think we're shifting more toward optimizing radiology workflow in the sense that, hey, we're just going to need these people. We're never going to be 100% correct. So let's try to cater toward them. Is that happening overall?
I think no matter how good AI gets, the doctor is always going to be at the center of the decision making. I think what the promise of AI gets to is it can remove a lot of the mundane tasks from your day. And things that enables you to practice at the top of your license, and hopefully gives you information that enables you to maybe do things like perfusion that you weren't able to do before or see before. But I think the center of every patient experience or decision should always be that physician, and then AI is a supplement to that to help them go faster, make better decisions. But I think you always want the physician at the center of the experience.
And we've talked a lot about how, like, AI and radiology. Can you talk a little bit more about what you're seeing on the horizon for clinical medicine?
I mean, we're at the end of the beginning. I know I used that phrase before, where we're able to give physicians information on that image, but it's going to get prognostic. Can you imagine getting into going and getting off your initial image and seeing an aneurysm and saying, "Hey, here's the size and here's the morphology and here's the optimal treatment for this, or these are the risks of complications using this type of device with this aneurysm." And the cool thing about this is that we're actually not that far off from that prognostic horizon. We're probably 2 to 3 years away from it. So you can imagine that with the stroke. You can imagine that with hemorrhagic. You can imagine that all these neuro PE. All of a sudden, you'll be able to characterize the clot, be able to make a recommendation on the type of catheter that's doing, and make have a list of the watchouts of saying these are the most common complications, and then translate that into an action plan after the procedure. And I think we're not far off from that horizon, and that's coming pretty fast.
Okay. How do you feel about some of these for-profit, kind of out-of-pocket preventative imaging screening programs that have popped up in the past couple of years? Like, for example, Pernuvo charging like, $5,000 out of pocket for full body MRI, just looking for any abnormalities, claiming like a 2% malignancy catch rate. How do you feel all those things are going to evolve in the future? Do you think it's going to continue like that, or is this too much bad where we're just catching false positives and causing a lot of fear and anxiety in patients?
I think the last two words that you phrase, I think that's okay. It's $5,000 for a scan, or for and to alleviate a patient's fear or anxiety. I think you have to be very cautious anytime you're using medicine, and that, if you're looking for things, nothing is ever perfect. Sometimes going at you see a lesion, whether it's there or not, getting to the knowledge, the uncertainty that can generate in the patient, then they feel like they have to do something. And all of a sudden you're doing a procedure that might not be necessary. That's a dangerous road as well. And so I'd look at that as, people have to make decisions for themselves, but I look at that with a high note of caution in terms of just it's you might be going down a pathway you don't want to go down. I think you always, if you are going to do a scan, you're gonna find something, and sometimes going after it could be worse than than and finding out there's nothing there at all. You're worse off than you would have been without having that scan.
Yeah, I think about like, just unnecessary biopsies occurring and then you get a pneumo.
Complications from
Yeah,
that.
you get
Yeah,
a pneumo
exactly.
and now
Yeah.
you're in the ICU with a chest tube for a calcified granuloma that popped up on your MR diffusion map. Like, I mean, it's just, it seems a little crazy, but again, it's like at the same time, there's this huge population where we're moving toward like preventative care and screening. Like, I was reading about these new technologies that are coming out for you to like screen your embryos and optimize for this eye color and this thing and pick the embryo based on that. I worry sometimes. I think there's going to be a huge population that can afford it, and they're going to start trending toward these out of pocket services, and we're just going to get this disparity in healthcare at some point too. What do you think about that?
Well, you know what? I'd flip the question around a little bit. I think where the disparity of care that matters is in patient accessibility to their information. I mean, you know this as well as I do, is, patients sometimes have to carry a CD to get their images, and they have to go to a hospital, the imaging room, which is down below the basement, below the morgue, and they're, getting this our CD, and they're carrying this over to their next physician. I think that's just a system that has to go away. And physicians being able to, or patients being able to access their imaging, being able to share it seamlessly across, the system, being able to share it with physicians, I think will be, and then you can eliminate all the repeat imaging that's needed. I think that type of redundancy and that type of accessibility is something where we should be, I think we are addressing it, and we should be addressing it, because I think that's a big source of inequity.
I think a lot of that can be fixed if, like, we start transitioning to more cloud-based packs and like having storage over there. And I mean, I'm sure you're pretty well versed. I know Rapid does some stuff with cloud-based stuff, but like, what are the barriers to this? Why is it taking so like? Why am I still, yeah, taking CDs and putting them and finding a CD drive? Like, why is this still happening? What is the barrier for large-scale cloud adoption?
I think that the first and issue with cloud adoption is cybersecurity. As you know, with IT, it's renewed emphasis. Every hospital is undergoing some sort of cybersecurity issue. Right now, there's a major chain that we work with just had their entire cloud network shut down because of a single email that was opened on a computer, and this is a huge network. And so that's why we've actually adopted a hybrid architecture. And it's cloud first, it's always cloud, but it also has an on-prem component. And the on-prem helps it go faster. But in the event of a cyber attack, that on-prem component allows the entire system to keep working. And especially when you're dealing with life-saving treatments like hemorrhagic stroke, PE, ischemic stroke, that's incredibly important to be able to keep it going. So I think one of the big barriers for adoption has been thinking through that cybersecurity element, and as they should, because the cybersecurity risk is real.
Hmm. And I think one of the things that I feel like when radiologists who are in practice look at technologies, our product as radiologists is our report, right? Our impression, our report, all those words that we're putting together, looking through the study, but you got to put it down on paper, and that's what you bill for. Are you guys or any other like, is it a general shift toward maybe moving toward reporting and speeding that up? Is that something that's on the horizon for us?
Yeah, I think everything should be going faster. I mean, I think with the radiology report, sometimes you guys are forced to do a preliminary read because you can't get the report out fast enough. By the time the report comes, maybe they're already in the interventional suite and saying, "Yeah, yeah, great, thanks." I think the faster you can get that information, and the more that whole process can be automated, the more that report can become relevant to the actual decision making of care. And I think that that is really one of our missions, is to put as much automation as we can, so you guys are actually thinking about the care of the patient and making the diagnosis on the disease, as opposed to trying to scrape some numbers here and carry it over there, and kind of the prosaic parts of the job, I think, can be really automated and make a big impact on the speed of care.
Okay. And talk to me a little bit about how, a established AI firm that's so honed in on one part of the body, one disease, how do you guys expand to include other things? Like, you go from stroke care to PEs to like, how does that happen? Is it just a matter of gathering enough data and running your algos and seeing what happens? Is that how it is?
Yeah, I mean, I think we learned some really important lessons from stroke. Of like what really matters in really, really, hard. I mean, stroke is really hard, and what information kind of matters to physicians, and how do you deliver it? And we've taken those lessons and applied it not only in the rest of the neuroscience space, but also throughout the rest of the body. So we now do PE. We're about to do aortic, and I think one of the cool things you say about the cloud um, is that we can now bring in any third party algorithm that is making a difference and offer it to our hospital partners. So as a part of this hybrid architecture, you not only would have access to rapid algorithms, you could have access to any other type of algorithms as well, or we can work with hospitals to help them develop their own algorithms. And so I think that's a really cool thing, a phase to be getting into, and I think it's going to be a big value add for the hospitals.
Yeah, I did not know about that until Dr. Albers was explaining it to me, and I was like, "Well, when do we get that?" Because that just sounds like the ultimate solution where you can just have, like, a, central vendor that's reliable, that's managing the bulk of the stuff for you. And then if you do have certain indications for this special technology that they're not necessarily doing, you plug and play. Does that is that okay with the people who are making that external software? Are they I guess they're cool with it as long as it's being used in the right way and they're happy because the technology is being used.
Yeah, I mean, it's efficient for the hospital because all of a sudden they're under the existing platform security clearances. It's efficient for the companies because then they don't have to go through all those IT securities. The platform has taken care of that. So I think it's a big boost for the system. But yeah, no, we're excited to move beyond. Neurovascular is always going to be our north star. We're always going to be the leader in that area. But taking those lessons and applying it to the rest of the body, I think is a pretty cool. It's going to be a cool phase for Rapid.
Yeah. How soon do you think that we're all going to be on a cloud-based system?
Oh boy, there's other people who would be able to articulate that a lot better. I mean, I don't know of any other industry um, outside of healthcare that still uses the fax. So I couldn't even begin to answer that question right now. Hopefully soon. Hopefully soon.
So as far as any new startups or new technologies that you've seen that are kind of coming up, anything that you're particularly excited about or you think is maybe a unique perspective on things that's really going to move the needle in the future? Like what do people have to look forward to?
Yeah, I mean, to me, there are so many possibilities with AI. And it's not just in, I mean, from the radiology standpoint, but it's also in, is it surgical planning? And I go back to prognostic. I think that that is going to be a huge next phase for AI and being a companion diagnostic as you're in your clinic. Being able to, help you interact with the patient, either highlighting the lesions, being able to illustrate some of these of what's going on in the pathology for the patient, I think could enhance the communication with the patients. Have patients having access to it and be able to bring it home and being able to share it with other hospitals is going to facilitate the speed and the transfer and eliminate a lot of that excess imaging and enhance the overall efficiency of the exchange. But I think what I'm really excited about with AI is the prognostic capabilities. And like I said, I think that's coming soon, but I think that's going to be a great new phase.
Yeah, we talked to them in a couple episodes before we were discussing some of the localized trials that they've done. One of the places I was talking about was UCSD, and they ran their ICU patients through like 150 clinical parameters through these algorithms that it's just pulling these 150 facts. And it was able to predict sepsis before anybody could have seen it. Patient looks completely stable, and it's like, "Oh, this guy's going downhill," and they reduced their mortality by 17% using that's
It's
insane.
amazing. Yeah,
Yeah,
that's
like,
amazing. That's
I mean,
exciting. Yeah.
it's like, you just say it 1 out of 5 people just because you're catching it early, that's crazy.
And the hospitals are sitting on mountains of data, and there's so much noise in this data. And so many times it's like it's unstructured data sets, so it's really hard to access. But once you start being able to access that, and I think AI will be able to make sense of many of these databases that it would have some of these unstructured data sets that we weren't otherwise able to access. And so we'll be able to get more and more insights out of that. So it's not just on the algorithm side, it's the amount of access or the AI can help you access data in ways that you're never able to access before.
Right, and spot trends before they even start occurring or to us before they start occurring. Yeah. And I talked to Dr. Albers a little bit about this, but I'm curious to know there's a big problem with, heterogeneity of data and how an algorithm trained on data from this side of the coast won't work so well on this side of the coast because of the differences in patient population. Could be a difference in technical artifact, how the images were acquired, slice thickness. There are so many factors that go into this. And he had mentioned that
even to train Rapid's data, you had to factor in like different scanner types like GE and Philips because they all do different things. How does that work? Is it just a numbers game? You just keep feeding from a diverse population and eventually it gets good enough?
Yeah, and this is an interesting point because sometimes people think that when's FDA cleared, oh, that algorithm is fine. The minimum clearance from an FDA standpoint is 80% sensitivity and 80% specificity on a limited data set. And so I think it's really important when you're looking at algorithms to see, hey, what size of the patient population was it trained on, and what's the real world evidence that you've been getting? Because many times, you get some performance parameters that it was approved on, and the real world performance is very different. That's why it's important for us. I mean, clinical literature and clinical validation is one of our North Stars. We always publish. We have over 700 publications, 11 New England Journal of Medicine publications. That type of rigor will enable you to get confidence that what was actually cleared is what you're actually getting. And I think that's incredibly important with AI to be able to be aware of that. And actually, that's something you should be looking at.
Yeah, absolutely. I asked this question to all the guests that come on here. Throughout your whole experience, you have a very unique perspective on medicine, on business, on, startups and all this kind of stuff throughout this whole process. And you might have mentioned it when we were talking earlier. What is one, eye-opening experience that really rewired the way you thought about medicine, about healthcare, anything like that?
Yeah, for me, it was sitting in medical school and trying to debate whether or not I was going to do a residency or go into do medicine or do business. And really, the deciding point for me is that if I did medicine or did the residency, I could probably help thousands of patients being a surgeon, doing individual procedures. But what really appealed to me about business was being able to affect hundreds of thousands, if not millions of patients. And that was really kind of my decision point, and that was kind of my rewiring of medicine of thinking of scale. Is like, can I do things individually? Or could I do things at scale? And frankly, I'm so glad that there are people out there who do it individually because they would do it much better than I ever would have. And I'm grateful for that. But for me personally, it was a question of scaling and trying to affect medicine and the lives of patients in that way.
Yeah, no, I think it works both ways because, now I'm more participating in some of the bigger trends and AI and stuff like that. And I'm like more by now I'm kind of seeing the light or inspired to like get involved in like these kind of technologies or the development of this stuff because I see firsthand how many people are impacted, right? You think about like thrombectomy times and all that kind of stuff and including this patient in the actual treatment group and all that stuff, it's pretty interesting that you can improve on this in one way and then affect so many people. And I want to tell that to medical students, like, they should always keep these kind of things in mind in this ever changing world that these options do exist. If you don't want to stay in residency, pivot over and start looking at some of these new things because you can make an impact outside of the hospital.
100%. And I think that the MD degree is actually a very versatile degree, and it has a lot of impact in business and value in business. All that being said, I'm married to a physician, and I see that interaction that she has with her patients and the impact that she can have with her patients. And it's an amazing thing to be a doctor. And again, super grateful for the people who are staying in medicine and treating those patients on a day to day basis.
Well, Dr. Stoffel, this was so helpful for us. We really appreciate it. Do you have any last couple things that you want to share with the people?
No, I think we covered a lot of material, but no, really enjoyed the experience, and thank you for the
We'll have
questions.
you
And
back on. We'll get your
it'd be great.
updated thoughts soon.
I'd
Okay.
enjoy that. I'd enjoy that.
So, in this episode, we discussed the future of AI and how we're moving toward just actually acute care to preventative care, and how AI is able to factor in different patient parameters to predict mortality rates, early sepsis, and even provide treatment recommendations for the clinicians. We also talked about how these AI systems are going to need constant monitoring, that we need to look at what the outputs are and how it translates to the actual patient and their outcome, and then go back and feed this information into the AI so that it can improve. Ideally, we're going to move to a future where these artificial intelligence tools are running in the background in every single hospital, flagging things that need to be flagged and predicting early disease so that patients can be treated earlier. If you guys like this content, please like, share, follow, subscribe, do whatever you need to do on those platforms to get our engagement up. We're going to continue with this series, and we're going to talk about more about how artificial intelligence is affecting healthcare and radiology as a whole.